Bipolar disorder is a mental health condition characterized by repeated episodes of elevated mood and depression. Mania is the term used to describe when elevated moods are severe and associated with psychotic symptoms such as delusions and hallucinations. Hypomania describes less severe mood elevations that usually do not require medical attention. A manic episode consists of, but is not limited to, the following symptoms: increased agitation, exaggerated self confidence, distractibility, and poor decision making. A depressive episode is recognized by depressed mood, significant change in weight, insomnia or sleeping too much, and suicidal thoughts, to name a few. All these symptoms severely impair one's social and cognitive functioning. There are three types of bipolar disorders: bipolar 1 disorder, defined by the presence of manic episodes, while bipolar 2 disorder is defined by depressive episodes alternating only with hypomania. Cyclothymic disorder is characterized by depressive and hypomania episodes which are milder than those in bipolar 1 and 2 and occur over 2 or more years. There is no simple answer to what causes bipolar disorder, but researchers have thought it may be due to chemical imbalances of the neurotransmitters noradrenaline, serotonin, and dopamine. Other brain imaging studies have suggested that it's caused by abnormalities in cortical and subcortical structures, specifically the amygdala and the basal ganglia. These hypotheses are not very certain. However, scientists are confident that genetics plays a significant role, since studies show that first-degree relatives of bipolar patients have a tenfold increased risk of developing the disorder. Some present treatments to minimize the symptoms of bipolar disorder include mood stabilizers such as lithium, carbamazepine, and valproic acid, and second-generation antipsychotics such as aripiprazole, olanzapine, and risperidone. It is widely recognized that bipolar disorder has one of the highest rates of comorbidities, one of which is substance abuse. Those diagnosed with mental health disorders are more prone to use addictive drugs, whether they are prescribed or recreational, as a way of coping with painful feelings and side effects, such as anxiety, depression, and loneliness. Studies show that 60% of bipolar patients have a diagnosis of substance abuse disorder, and alcohol is the most common addictive drug of choice, followed by cannabis, amphetamines, and cocaine. The reason for this co-occurrence is currently unknown, but speculated that both disorders have overlapping neural action in the same brain regions that subserve emotions and impulses. Unfortunately, there are currently very little studies to explain if there are any genetic factors underlying the relationship between bipolar disorder and substance abuse. However, it can be explained through three potential hypotheses. One study showed that 38% of bipolar individuals in a manic phase used depressants like alcohol, and 13% in the depressive episode used heroin to self-medicate. For the second hypothesis, drug abuse is not only a consequence of bipolar disorder, but can also cause it. One study found that 75% of 77 hospitalized patients had their first manic episode occur 1 year after their start of substance abuse. The final hypothesis proposes that bipolar disorder can cause substance abuse because individuals will have higher impulsivity and more desire to participate in pleasurable activities, especially during manic episodes. Something to also take into consideration when studying these simultaneous disorders is the age of onset. The typical age of onset is about 25 years old, but can also occur in adolescence. Findings show that individuals who develop bipolar disorder between the ages of 13 to 18 were 9 times more likely to develop substance abuse than individuals who develop bipolar disorder before the age of 12. Bipolar teenagers tend to have multiple comorbidities, such as conduct disorder, oppositional defiant disorder, and panic disorder, along with violence, impulsivity, and stress. These conditions can explain why adolescents with bipolar disorder are more prone to abuse certain drugs. These dual diagnosis patients have more negative consequences than patients with bipolar disorder alone. Those with substance abuse experience mood symptoms earlier on, have higher rates of anxiety, and increased suicide attempts. There have only been a limited number of double-blind studies which tested certain anticonvulsants and mood-stabilizing drugs, which can treat substance abuse bipolar patients. Carbamazepine was found to reduce cocaine-positive urine drug screens, and the bipolar patients also reported having less of cocaine cravings than the placebo group. Lithium in combination with divalproic sodium was tested in alcohol-dependent bipolar patients, and results show that it decreased the number of drinks per day and the number of drinking days compared to the placebo group. Naltrexone has also shown some therapeutic benefit in alcohol dependence, as it was associated with reduced alcohol use and craving, as well as modest improvements in depressive and manic symptoms. The limitation with these studies is that they use small sample sizes ranging from 6 to 30 bipolar patients, making it difficult to assess whether these drugs are effective at relieving substance abuse in these individuals.